Immunotherapy in gynecologic cancer is a therapy that's been a long time coming because it certainly is an area that's been under investigation for a long time now that I expect all of us are going to hear much more about in the decades to come. And I'm excited today to talk about some of the preliminary information, which is exciting. This is truly a new way of approaching the cancers that we treat. Potentially allows us to get away from kind of the cycle of cytotoxic chemotherapy and the attendant toxicity that goes along with that. And if I can get the slides to work. Briefly, I think it's difficult to talk about cancer immunotherapy without going through a little bit the principles of cancer immunotherapy, since a lot of the factors and kind of relationships within the cells are different than we normally discuss regarding cytotoxic chemotherapy. So I'm going to talk a little bit about some of those principles, a little bit generally about therapeutic approaches in cancer immunotherapy, and then more specifically about what's been done so far in immunotherapy and GYN cancer. A lot of the data in GYN cancer are phase 1 trials. There's some smattering of phase 2 data. A lot of the published data is really kind of abstracts from meetings, and a lot of the things that I'll present are really things that have been presented at meetings rather than in peer-reviewed journals so far. But it is certainly an exciting area and one that I'm excited to talk about. When we talk about tumor immunology, there's a few kind of different pieces to this puzzle that I'm going to discuss with you. Some, first, kind of what are the cells that are involved in tumor recognition and rejection. A little bit about the concept of the immune synapse and what that means for cancer, for targeting this area, and then to talk a little bit about how tumors evade immune surveillance and how we can potentially interact with that process to allow these tumors not to evade. And if this is giving you deja vu about immunology courses that you've taken before, I'm going to do my best to simplify this, and we're not going to spend too much time going into the nitty-gritty of this, but suffice it to say that there are some important cells that are involved in tumor recognition and rejection. These include CD8 lymphocytes, which are also known as cytotoxic T cells, and CD4 lymphocytes, which are also known as helper T cells. These lymphocytes help to initiate distinction between self and non-self antigens through recognition at the immune synapse, and we're going to talk a little more about that and why that's important. We also have natural killer cells. Natural killer cells do not require antigen presentation for cytotoxicity. There are also a kind of host of other cells that interact with and may inhibit some of the other T lymphocytes. So those include T regulatory cells, these myeloid-derived suppressor cells, and then macrophages. Both M1 and M2 macrophages have some different roles that may be either stimulatory or inhibitive of the immune process. So the immune synapse is something I'm going to spend a little bit of time on because it's important somewhat to understanding some of the therapies that we're going to talk about. So at the immune synapse, you have these CD8 chains that recognize MHC class 1. So this is our CD8 T cell. This is our antigen-presenting cell. This process also then initiates CD28 binding to CD80 and CD86, which leads to downstream activation of a number of factors, co-stimulatory and otherwise, resulting in CTLA4 feedback production, which is brought to the surface, and the CTLA4 coming to the surface kind of is important in the process of the immune system killing these cells. However, cancer antigens, when they're present for a long period of time, can upregulate another important class of molecules called PD-1, programmed cell death 1, and can also select for programmed cell death ligand 1 expression. So PDL1 and PD1 interact with one another And over time, this chronic presentation can cause a phenomenon called peripheral exhaustion, which is one of the ways that we think cancer cells evade immune recognition and surveillance. And so the CTLA-4 class on the previous slide, these PD-1 and PD-L1 sites are important because there's a significant class of medications called immune checkpoint inhibitors that we're going to spend some time talking about today that are antibodies that are that target these sites. So let's talk a little bit about tumor evasion of immune surveillance, and there's a process called cancer immunoediting, which is another stepwise process which is believed to be part of the way that our tumors evade immune surveillance. So if we have normal tissue cells here that are transformed into carcinogenic cells by a number of processes, there is a process of elimination where our immune system recognizes these tumor cells and gets rid of them. A process of equilibrium where the tumor may change, be dormant for some period of time, and through editing may eventually lead to a kind of a new genetic complement in the tumor, or changes in surface expression of cells which allow it to escape immune surveillance and continue to propagate. That's grossly oversimplifying, but I'll spare you the gory details. So there are a few different mechanisms by which we think tumor cells can escape immune surveillance, one of which is the loss of specific antigens on the surface or antigen machinery such as MHC class 1. Tumors can manipulate cytokines that either promote, suppression of the CD4 or CD8 lymphocytes. They can upregulate expression of those PD-1 and PD-L1 receptors that can promote peripheral T-cell exhaustion. And some cell signaling pathways, which were originally thought to be growth accelerators, for instance, the KIT pathway that has gotten so much attention for GI stromal tumors and the ability to target that with Gleevec, or are actually now believed to be immune escape mediators that are being targeted by that therapy. So there are lots of different therapeutic approaches that are being studied in order to target these aspects of cancer immunotherapy. And those include cytokines, they include T cells, and this class of medications called checkpoint inhibitors that we're going to spend more time talking about today. There's ways to manipulate T cells or tumoral or aspects of those, the tumor infiltrating lymphocytes. There's oncolytic viruses that have been used, and therapeutic vaccines, which are fundamentally different than some of the prophylactic vaccines, which are in such common use for the prevention of HPV-related infections. So just real quickly, because some of these names are going to be present in a lot of the trial data that I mentioned. The immune checkpoint drugs are monoclonal antibodies against primarily at this point the immune checkpoints at CTLA-4, PD-1, and PD-L1. So these are among the kind of first ones that had targetable areas that are have therapies that have been used in a lot of these trials. And so some of the kind of common ones that we're going to talk a little bit more about include drugs like ipilimumab, which is a CTLA-4 checkpoint target, pembrolizumab, which has certainly gotten a lot of attention in the last 6 months, and nivolumab, which are both PD-1 inhibitors, and then avelumab, atezo, durvalumab, which are all PD-L1 inhibitors. So let's talk about ovarian cancer first, and kind of relevant to ovarian cancer, there are a number of immune checkpoint inhibitors that have been used in early trials, some of which are reported and some of which are ongoing. But certainly because a lot of this is phase 1, either phase 1 expansion or phase 2 trial data, these aren't trials that are randomized. The things that we're interested in these trials are really the response rate and using that kind of to compare that to historical cohorts. Most of these trials are done in patients who are heavily pre-treated or very poor prognosis, like primarily platinum-resistant or secondarily platinum-resistant patients. So when we have kind of phase 2 data showing response rates or overall response rates in the 10 to 20% range, especially when coupled with stable disease rates that are higher than that, this is kind of exciting new ground, because a lot of the toxicities from these immune checkpoint inhibitors are fairly minimal. So in ovarian cancer, there is phase 2 data reported for nivolumab, which is an anti-PD-1 antibody in platinum-resistant patients. 20 patients were treated, about a 15% response rate, but stable disease in 45%. There's phase 1 data for avelumab and pembro, both in platinum-resistant patients, with response rates in the 10 to 11% range, but stable disease rates in the 30 to 40% range. And there is some combination phase 1 data looking at combinations of, in this case, a PARP inhibitor in combination with an anti-PD-L1 inhibitor. This is a study looking at patients who are BRCA positive, but overall response rate is 17% with 83% stable disease. There are a number of ongoing trials, including a randomized trial, the Javelin trial, which is a phase 3 study looking at Doxil plus avelumab, the anti-PD-L1 antibody listed above, versus Doxil alone in platinum-resistant patients. There's several trials in using immune checkpoint inhibitors in combination with cytotoxic chemotherapy for recurrent disease, for maintenance therapy, and an NRG oncology trial in combination with primary therapy that we await preliminary results from, because I do think this is a exciting new area. So another area of immunotherapy is therapeutic cancer vaccines, and in ovarian cancer there are several of these that have been studied. One of the earliest reported ones is a vaccine to NY-ESO-1. The initial NY-ESO-1 was one of the kind of early cancer vaccines that were showed antigenicity in ovarian cancer, but there are a number of modifications that were introduced over the years which allowed it to be more effective. So the most current data, this modified NY-ESO vaccine with some epigenetic modulators did show some early promise in combination with chemotherapy, and I think as time goes on and we get more data, sometimes therapies that we had studied before but may have abandoned assume new relevance. But I do think this was an important early vaccine to establish that that these sort of cancer vaccine therapies in ovarian cancer were a reasonable area to explore. More recently, some dendritic cell vaccines with using the HER2 new antigen in combination with cyclophosphamide were used in a number of patients with recurrent ovarian cancer whose disease was in remission at the time, but with that, kind of starting in remission, but recurrent disease at 90% 3-year disease control rate. In a small group of patients, that's provocative, but not definitive by any means, and certainly merits further study. But dendritic cell vaccines are an area that will continue to be developed. More recently, whole tumor cell vaccines and personalized peptide vaccines are looking to be kind of a wave of investigation in the future, particularly being able to personalize vaccines to a patient's particular tumor based on information that you're able to acquire from that individual patient. Certainly shows there's a lot of interest. Initially, there was a lot of interest in adoptive cell transfer. This is a process by which tumor-infiltrating lymphocytes are isolated from a patient, collected, expanded ex vivo outside the patient, and then they're subsequently reinfused. The expanded product is subsequently reinfused. And for those of you kind of familiar with some of the exciting melanoma trials in the last 5 years, there's been significant success in this area, up to kind of 50% of patients having a dramatic response, particularly after administering lymphodepleting chemotherapy. And the addition of this lymphodepleting chemotherapy step was important. The small number of trials looking at this in ovarian cancer really predated the recognition of the importance of that lymphodepletion step. But at least one early study looked at adoptive cell transfer after primary debulking and primary chemotherapy, which is a correlate somewhat to this lymphodepletion process, and did show some early promise. But I do think that this is not an area that will that's going to go abandoned in ovarian cancer, and I do think certainly early on was a lot of promise in an area that will be we'll see more of in the future. So moving on to cervical cancer, there's some exciting data looking at immune checkpoint inhibitors in cervical cancer, and I think all of us will agree that new therapies in cervical cancer and endometrial cancer are particularly exciting, because while we have well-established first-line therapies for both of these cancers, when we have patients with recurrence or we're faced with any sort of kind of widely metastatic disease, we all recognize how limited our options are in these patients. So there are a couple reported trials looking at immune checkpoint inhibitors in cervical cancer. The initial Keynote 28 study looking at pembro in recurrent cervical cancer had an overall response rate of 12%. And then a later trial, the Keynote 158 study, which included not only recurrent cervical cancer but other cancers as well, again looking at pembro. These were patients that were included independent of the tumor PD-L1 status, and had a 17% response rate, despite not screening for patients that were PD-L1 positive. The Checkmate 358 study was a study in recurrent cervical cancer looking at nivolumab, an anti-PD-1 inhibitor, with a favorable response rate of 21% and a stable disease rate of 71%. There are several ongoing trials looking primarily at either locally advanced or metastatic cervical cancer with positive lymph nodes, so poor prognosis population, looking at ipilimumab after primary chemoradiation, and then a phase 2 study looking at comparing pembro given concurrently with chemoradiation versus pembro given sequentially after chemoradiation. And it probably will be several years before we have that mature data. In the same way that HPV vaccines have shown success against HPV infections and reducing the incidence of dysplasia, there is some exciting data about therapeutic cancer vaccines in cervical cancer. So a couple reported trials, both looking at Listeria monocytogenes vaccines. The initial study was a study from India looking at 110 patients using this Listeria vaccine with an HPV-16E7 fusion protein given with or without cisplatin. Ultimately analyzing the data, it didn't seem to make a difference whether patients got cisplatin or not, but these patients all had recurrent cervical cancer. Clinical response rate of about 11%, progression-free survival of 10 months. This was preliminary but exciting, since these were all recurrent cervical cancer patients who had an extremely poor prognosis. Prompted the initiation of a GOG-NRG study looking at the Listeria vaccine, similar fusion protein in recurrent cervical cancer. 50 patients were treated on this trial. 25 had already received bevacizumab. And so the 12-month overall survival rate of 38% compared favorably to the previous overall survival rate of 30% of just treating these patients in a similar situation with bevacizumab alone. And so an area to merit further study. There are some ongoing trials looking at HPV-16 and 18 specific vaccines, either alone for the treatment of recurrent cervical cancer or in combination with cytotoxic chemotherapy with or without bevacizumab for advanced cervical cancer. Endometrial cancer is also an exciting area, not only because we're fairly limited in the treatment options that we have available, but because even before the kind of access to the drug we're going to talk about, pembrolizumab, because of the Lynch syndrome association, we have kind of learned quite a lot about endometrial cancer, the importance of mismatch repair proteins, what microsatellite instability means in the setting of trying to determine which patients with endometrial cancer may have that as part of a Lynch syndrome. So about 25% of endometrial cancers express defects in a process called DNA mismatch repair, which histologically is manifested by errors commonly referred to as microsatellite instability. So immune checkpoint inhibitors have become been given a lot of attention in the last few years, initially because of a phase 2 study of pembrolizumab in MSH high non-colorectal tumors, where the response rate was 71%. There were 2 endometrial cancer patients included on this trial. One had a complete response and one had a partial response, but certainly prompted a lot of interest. So the Keynote-28 study was a phase 1b study, including a couple different tumors, but that were all PD-L1 positive. Treatment with pembrolizumab, but the subgroup of patients with recurrent endometrial cancer, at 24 patients, 3 had a partial response and 3 had stable disease. The Federal Drug Administration in the United States recently approved pembrolizumab for MSH high tumors who have kind of progressed on standard therapy or have no other treatment options available. So testing for MSH high tumors in our endometrial cancer patients has been something that we really have done for the vast majority of patients who progress on standard therapy, since the remaining treatment options are fairly limited, and this is a novel therapy with acceptable toxicity. There are lots of trials opening soon with pembro, with or without chemotherapy, for advanced or recurrent endometrial cancer at various kind of stages of recurrence, and we look forward to the results of those trials. So in conclusion, and hopefully I haven't lost everyone in the word salad of kind of new terms and whatnot, but cancer immunotherapy has progressed very rapidly in the last decade. It's certainly been under investigation for longer than that, with active exploration of therapeutic interventions in most cancer types. Primary therapeutic interventions in gynecologic cancer have focused primarily on immune checkpoint inhibitors, therapeutic cancer vaccines, and adoptive cell transfer. And there is current utility in testing patients with recurrent endometrial cancer for the presence of microsatellite instability or high microsatellite instability for potential eligibility for treatment with pembrolizumab. With that, any questions? Yeah. So the way that we generally approach it is patients with recurrent or metastatic endometrial cancer are usually treated with cytotoxic chemotherapy first, if and when they recur, depending on whether they had hormone receptors present or not. The decision is usually I think at that point, unless it's a low-grade tumor, we know that there's acceptable response rates to endocrine therapy, and so that's certainly a reasonable option. But we're generally sending tumor for testing at that point, and if they're microsatellite high, then pembro is certainly an option. Correct. And our policy is, at least by all of our patients with endometrial cancer get immunohistochemical testing for mismatched repair proteins at diagnosis. We do that primarily for Lynch syndrome screening. Pembro? We use it, if the, I would say many of our sarcomas were testing for mutations, but I would say, currently we're using it more commonly for MSH high tumors. Sure. I think Pembro is being tested in anything that has a MSH high expression, and many sarcomas do because they're relatively unstable, and you can find in most sarcomas most mutations present. Unfortunately, that hasn't translated into a lot of therapeutic efficacy in sarcomas because it's such a diverse, unstable cell population. But the correct, correct. Yeah, I think while we do treat a large population of sarcomas, certainly the number of patients with recurrent or metastatic endometrial cancer that we have is significantly higher, and I think because of that, we're using Pembro more frequently in those patients, just because of the numbers.